3, 2, 1. I think you're live everywhere.
Hello, everybody. I am Dr. Rahi Victory, reproductive endocrinology and infertility specialist. Welcome to Fertility Fact or Fiction, our weekly show where we share the best and the latest and the greatest in the scientific world with you and try and break down all the myths, get rid of all the misinformation, and hopefully destroy the use of the ERA test.
That's our goal here.
Because that's definitely one of our goals here. Welcome to the show. If it's your first time joining us, we do kind of a article review usually, and then we go into questions and can't answer personal patient level questions, but general questions about topics, no problem. And I have my trusty friend Tariq Ibrahim from Ibrahim Strategies Group with us as well. And so, yeah, we're going to go through some information. Want to say a huge thank you to all the people on TikTok who watched our recent video on exercise and pregnancy and found some hilarious comments, which I do want to respond to. So I think that's really important. And I want to follow up with some information about the ERA test because there is some new information out again. We reviewed it on the show not too long ago, but there is even more information coming out on the fact that it is more useless than we originally thought. Yeah.
Hello from Holland.
Holland. Oh, it's our friend.
That's your friend.
It's our friend from
And
Holland.
hello from Georgia.
Georgia, like the Republic of Georgia or down south Georgia?
I'm thinking down south.
Down south? It might be my cousin. You never know. Okay, so hopefully you guys have all grabbed something to eat. I want to go over an article that I recently found out about on human reproduction. So Human Reproduction is one of the premier fertility journals. There's Human Reproduction and there is Fertility and Sterility. There's a bunch of other ones. I try and read as many of them as I can, but those are the two big ones. So we generally look at Human Reproduction and at Fertility and Sterility for our two major articles. Is the sound good?
Yeah, it sounds cool.
Oh, yeah. Tariq wants to know if the sound is good, guys, because we have this new very phallic microphone that we use.
The constant reference.
We're going to end up naming it something funny.
No, we're not.
Listen, in regards to the ERA test, what we showed you on the show recently was that the ERA test can't even do what it claims to do. So there's a study by a scientist by the name of Doyle. And in that study, they did ERA testing for everybody, but ignored the results of the ERA test and went ahead and transferred everybody at the same time, which was day 5, of progesterone use or after 5 days of progesterone use. So the important thing with that is they then had the information to show what happens if you tested receptive on the ERA and transferred on day 5, and what happened if you tested non-receptive on the ERA, but you still transferred day 5. So clearly, let's all think about this for a second. If the test works and you are non-receptive, then the ERA test should result in the fact that those people who went ahead and did a day 5 transfer anyways, even though they were non-receptive, they should not be getting success, right? They should have a lower success rate because they were non-receptive. And if the test can actually detect that you're non-receptive, then you would know, okay? Whereas the group that was receptive, they should have a good success rate. The group that was non-receptive, they shouldn't. So in this trial, which the people that did the trial didn't even realize they had this data. Somebody else actually analyzed it from their study. The group in that trial, or the data from that trial, demonstrated very clearly that the success rates for the people that were ERA receptive versus ERA non-receptive, but all transferred on the same time, exactly the same success rate. And the slight difference that was there was actually in favor of not testing. And when they actually went through and calculated the data, they showed that there's like an 11 or 12% decrease in success when you follow the ERA test. Why am I bringing this up? I met a lovely couple from California recently who reached out to me who wanted my help and said that their clinic did the ERA test. And I said, why? And they said, oh, our doctor still believes in it. And I hear this all the time. There are literally famous Instagram doctors who are very well known and very well trained from big name schools who still believe that the ERA test works despite all of the evidence that it doesn't. And I said to them, like, it doesn't work. And they said, well, our clinic's telling us it does. And I said, here's all the evidence. Like, and I literally screen shared my entire file of all the different studies of ERA that don't work. So there's a new one coming out. It's in Human Reproduction again. It's called Personalized Embryo Transfer Guided by Endometrial Receptivity Analysis, a systematic review with meta-analysis. So these guys, like, basically put everything together and mashed it up into this soup and spat out the data to see what they get. And the result of it is, I'll give you the summary answer. The endometrial receptivity test is not supported by current published evidence in women without repeated implantation failure, while in women with RIF, more research is needed to assess a potential benefit. In other words, doing personalized embryo transfer, the ones that are guided by these ERA tests, is useless. This is from a meta-analysis. Every single trial so far has shown no benefit. The Richter assessment of the Doyle trial shows it's actually detrimental and it can't even do what they claim that it does. So it is super important for you all to remember that it is useless to do the ERA. If your clinic is telling you do an ERA, there's three things you know automatically. Number one, that clinic does not study because there are many studies coming out showing that the ERA is useless. Number two, the doctor doing it genuinely is not paying attention to what's going on in the scientific community. And number three, the fact that they are potentially decreasing the chances of success. Turn around and run the other way, guys. Like, that just doesn't make sense for anybody to be doing. I'm happy to debate anyone. I know the data on this inside out and backwards. There is no value to doing the ERA test. The other thing that I'd like to bring up tonight for you guys is about our recent video on TikTok. We got a huge number of views, and I got totally flamed by tons of people for saying that walking is not useful. Well, I said to myself, okay, you know what? I'm going to go do some more research. I want to make sure that what I said to them was actually correct because we did the research for it, but I wanted to double check everything and make sure.
Give them a recap of.
Yeah, so the bottom line for exercise in pregnancy, which was what the topic of the video was that walking by itself is not very useful. It's a 2.1% reduction in your risk of gestational diabetes. So everybody got on and said, oh, you don't know what you're talking about. And I love this. A whole bunch of people that were not physicians told me I didn't know what I was talking about, which is, okay, I'm willing to accept that maybe I made a mistake, but it's always funny hearing it from people who have no scientific training whatsoever, telling me that I don't know what I'm talking about when literally I spent almost all of my time studying all day long. So I then took that information and I said, I'm going to go learn. So our video said basically, walking, not very useful. You may as well skip it. It's not going to help you. And then we said that moderate exercise, moderate intensity exercise, hugely beneficial. Easier labor, less gestational diabetes, less preeclampsia, less preterm labor, safer babies, like everything, less depression even, less anxiety, like loads of benefits to doing that. And then we showed that in the group that does really intense, severe, heavy lifting, if you were doing it before, you're probably okay. But if it's your first time doing it, it can actually increase your risks of having abruptions, preterm labor, things like that. So the balanced position in the middle where you're not doing too much, but you're also not really just walking or being a couch potato, those are the best. That's the best spot to be in. You don't want to overdo it. You don't want to underdo it. You want to be kind of light to moderate or moderate, level exercise for at least 20 to 30 minutes every day as much as possible. So then I said, okay, all these people are claiming walking was amazing for them, whatever. So first and foremost, if you are trying to prevent gestational diabetes, walking is not useful. Unless you're doing very brisk walking, and you're walking a lot, like 4 hours a week, nonstop walking. So if you have time to walk 4 hours a week, great. If you're doing it at a brisk pace, you're walking a lot, then it will work. I find most women get a very sore back. They get sore joints, sore knees when they're later in their pregnancy. So I'm not sure that's going to work. But if you can do it, great. God bless my cousin. She's an Olympic marathon runner for Team Canada. She actually ran in the Olympics in Atlanta. And she ran 10K a day when she was pregnant, right up until I think the day before she delivered her kid.
No way.
Yeah, like hardcore runner. So if you can do that, great. You're going to have minimal risks. You're going to be super healthy. Now, she wasn't walking, she was running. But as long as you can walk briskly, that's perfectly fine. But if you are walking at a casual pace, you actually have no benefit. And there are multiple studies which show that it will not prevent anything. Walking just doesn't burn very much calories, guys. We all walk around all day as part of our jobs, as part of our work. Trust me, I'm running from room to room, office to office, the lab, the OR, constantly running around. I'm not losing weight as a result. I'd be see-through or two-dimensional at this point if that worked, right? So walking, not helpful. Moderate exercise, hugely helpful, but walking not helpful if you are trying to prevent gestational diabetes. If you are trying to treat gestational diabetes, where you already have a sugar problem and you want to control the rises and falls of your sugar, of course walking is going to help you because you're burning off some calories. You're not burning off a lot, but at least you're stabilizing your insulin and sugar load by constantly burning a little bit in the background, and that can definitely be helpful. But to really make a difference, even with gestational diabetes, again, it has to be moderate intensity exercise. The low level exercises don't really do much. And if you look at the research on this, which I spent half the day diving into, the low level or light kind of casual level exercise, things like walking, don't actually help. They're not beneficial. Their confidence intervals cross 1, which means there is no statistically significant benefit. So you could literally do almost nothing or do the walking and you're not going to have a difference in outcome. It's not until you actually get into the heavier exercise where you're going to see a benefit. So message for tonight, I'm happy to take on any challenges from TikTok, which seems to always be a thing.
I like it.
Oh, we never connected, by the way. We should probably connect.
Yeah.
Oh, actually, you don't need to. You can just screen share. No, I mean screen share from the phone to this. TikTok. Oh, or are you getting it there? You're getting it there.
Yeah, you have an article you want to share?
No, that's okay. We're good with the article. So anyways, ERA does not work. If your doctor is telling you the ERA does not work, they're at least 2 or 3 years behind in knowledge. If they're telling you it does work, they're 2 or 3 years behind in knowledge. The ERA is useless. Do not waste your money on the ERA test, please, I beg you. It actually looks like it decreases your success rate. And as far as walking in preventing gestational diabetes, it does not prevent gestational diabetes. It may help reduce your sugars once you're a gestational diabetic, but even then it needs to be more intense walking. Light walking, like a little walk around the block kind of thing, it's not going to help you guys. And that's not me saying it because I'm trying to disparage all of those of you who are trying. I am all for the fact that you're putting in your effort. And if walking is all you can do, for God's sakes, don't overdo it. Don't strain. Don't put yourself at risk. No one is suggesting you do that. But if you can do more than walking safely without harm to you or your baby, it is better for you in your pregnancy to do so. And that's just me presenting the science. This is not my opinion. That's what the facts and the studies show. Hope you guys enjoyed that part of this. We're going to go straight to questions now. So I kept that part short so we can take whatever questions we have.
So you have hello from Georgia and you have hello from Delaware.
Oh, wow. Delaware. Wow, we've never had a Delaware. Hello from Delaware. Good to have you on.
Would a fertility clinic or doc consider chemical pregnancies as a loss or miscarriage when filling out paperwork?
Oh, good question. I mean, I would. It is technically a miscarriage and it's certainly a loss. So yes, it kind of depends on how you define miscarriage, but yeah, we would. I mean, it is a type of miscarriage for sure.
Does one get a period while doing luteal phase stim? Where does the progesterone come from if no period?
Does one get a period if doing a luteal phase stim? You will, but it'll probably happen twice. So it'll really screw up your period for a while. You can actually sometimes end up with a period during your luteal phase stim if your luteal phase stim goes long enough. Or then another period during your follicular phase stim, right when you're supposed to start your luteal phase in the next cycle. Where does the progesterone come from? So you're still releasing an egg prior to your luteal phase, so that's producing progesterone. So that's where the progesterone is coming from.
What are your clinic's wait times currently for a donor embryo? Is the price different if it is PGT tested?
We don't charge anything different for any type of donor embryo. The only things that are different are there's some additional costs for legal stuff that we have to do and paperwork, but the embryo transfer fee is still the same. As far as PGT versus no PGT, it makes no difference. We still charge the same, and our prices are super low for doing those kinds of things. Wait time, it's not so much a wait time, it's whether or not we have an embryo that suits you. So some people want something specific. I want black, I want white, I want Asian, I want Hispanic. So depending on what you want, we may or may not have embryos at any given time. I will tell you that donor embryos go lightning quick. We rarely have them because there is a wait list, and as soon as they become available, we call people, and most of the time they kind of snap them up and take them. So it depends on what you want. Sometimes we have embryos that are left because they're from a particular racial group that maybe isn't that culturally in tune with accepting donor embryos. Other times we have ones that happen to just be there because someone donated them that day. So it all depends on what has happened with the embryo and what the characteristics of the biological parents are in regards to who's actually trying to, adopt those embryos.
How would you treat an IVF patient with long APTT blood clotting?
So you need to be on aspirin and heparin if you've got a blood clotting. If you've got a thrombophilia, you need to be on a aspirin and heparin protocol. We use low molecular weight heparin now, so whether you're on, Lovenox or Inahep or one of those, it doesn't matter, whichever one you want.
I have stage 4 endometriosis. Mm-hmm. What are my chances of pregnancy? I'd like to know.
Great question. I can't tell you what your chances of pregnancy are because I need to know everything, right? I need to know what your tubes are like. Are you thinking IVF? What's your ovarian reserve like? What's your BMI? What's your age? What's your partner's sperm like? There's a lot that goes into it. It's not just here's your number. What I can tell you is that we know that cases with severe endo reduce their chances of success with IVF by about 50%. So there is definitely a decline in success. But what's your chance? It could be as high as 80% normally. So now you'd be like 40, 50. Or it could be as low as 20% if you're 43. And then now you're looking at 10%. So I don't know. I need to know way more about you. It's a great question, but not one I can answer without a lot more information. A lot more. You're really scrolling, dude.
Question. Thoughts on the use of dexamethasone during IVF stim for a patient with endometriosis and a DOR AMH 1.33, no unit given?
So dexamethasone we've reviewed on the show years ago. It actually is beneficial. I don't use it because we have our patients already on a lot of different molecules and substances and vitamins and supplements. And I kind of feel like there comes a point where some of these things may start interacting with one another and we may not be helping everybody. So I haven't really gone down the dexamethasone pathway, but there would be lots of reasons to consider it. So dexamethasone and DOR definitely being shown to be beneficial. So that's a reasonable consideration. Dexamethasone with endometriosis, we know that patients with endo have inflammation and their immune systems are overactive. That's a given. It's shown in so many studies, I probably, fill a library with that. So the reality is that suppressing some of that inflammation is probably a very, very reasonable, good idea. So dexamethasone will help with that. So as far as the specifics of what you've told me, is it reasonable for someone with endo and someone with DOR to consider doing dex? Absolutely it is. I don't do it just because, like I said, we have so many other things going into it right now. We don't necessarily think that it's going to be that beneficial. But we're focusing a lot on other primers, things like testosterone, human growth hormone, avoiding birth control pill, not using estrogen priming. So there are things you can do that will improve your success rates.
Just for yourself.
Hi, Soraya. One of these days you have to tell us why you're awake at 3 a.m. or 2 a.m. in Holland.
Question.
I want to know if she's Persian.
I don't know.
Soraya, you got to tell us if you're Persian, because Soraya is a Persian name.
Let's see what she says.
Yeah.
She'll respond.
I'm sure she will.
Is there evidence to support a beggar egg retrieval during a second round of IVF if you have a low ovarian reserve?
No. There is no evidence that supports the idea that your second egg retrieval will provide you with more eggs than the first. There is some kind of weak evidence that shows that people who stim will do better in a subsequent stim overall. I'm not aware of anything specific to DOR cases. If there is information out there, I'd have to look it up, but I've never seen anything like that, so I'm not aware of that myself. But I guess it's possible in theory. Yeah, I don't know. I'm not aware of anything that says that.
Hello, Dr. VNT. What are your thoughts on intralipids? Is it worth it if I have high NK cells?
So there's a lot of data on intralipids. Some studies saying yes, some studies saying no. The meta-analysis does show a benefit. Most systematic reviews show a benefit. We've been using it for 12 years. In our hands, it definitely shows a benefit. In particular for NK activity, there is clear data that shows that you can suppress NK cytotoxicity with intralipids. So I believe in it, and I use it all the time. I actually was thinking of bringing a really sciencey paper on for tonight. I held off because I think sciencey papers probably bore you guys. Let us know in the comments. If it doesn't bore you, we'll share that too. But there's actually one looking at the impact of hormone replacement therapy, frozen embryo transfers, and gonadotropins on your immune milieu and what it does to the T helper profile, what it does to your NK activity. And it's not good, which is why we don't use the traditional hormone replacement therapy method, because it does provide you with the lowest chance of success. It's the most inflammation, it's the lowest chance of success. Letrozole is way better, so that's what we've gone with.
There's someone asking if you know a Mike Hawk or a Jenna Tolles.
I can't admit to knowing anybody.
Oh yeah, that's right. What is it called? Doctor
Patient
Privileges?
Doctor Patient Privacy, I guess.
There you go.
Yeah.
I don't know them.
Yeah.
The relevancy of that is...
Tarek doesn't know them. He can say whatever he likes.
Whatever.
I cannot admit to knowing anybody. So I literally see patients who go, oh, my sister told me to say hello, and I know that they're sisters, and I still can't acknowledge that I know they're sisters. So, yeah.
Is it possible? Oh, before that one. Is there evidence to support a better egg retrieval during a second...
you asked that.
I did that?
Yeah.
Okay. Hello, Dr. VNT. I did the ovarian reserve question? I feel like I didn't.
Not ovarian reserve.
Yeah, so is there evidence to support a better egg retrieval during a second round of IVF if you have a low ovarian reserve?
That was the one you asked.
Oh, that's the one I wanted.
Yeah.
Okay. Is it possible to completely avoid using estrogen when preparing for transfer due to a history with endometriosis? And what would your protocol look like?
It is possible. It doesn't always work, but letrozole is the best approach for that. So we use Lupron for 3 months with letrozole. Then we extend the letrozole for an extra 5 days. Then we just give the patients a smidgen of estrogen, only if we have to. A smidgen, like 1 milligram, 2 milligrams. And that's it for the whole day. Not, 4 milligrams 3 times a day, which is insane. So we are very judicious about what we use. And then we use lots of supplements. And then we use high-dose progesterone. So that's our protocol.
Do you know about the genetic disease TARP?
No.
TARP?
No.
Okay. He was asking if this is a fertility show. TARP syndrome is what it's called. Sorry.
No.
Okay. Also an easy one. Hello, Dr. V. Could you please explain how to stop the drugs at 12 weeks pregnant?
Oh,
My nurse
the
told me
drugs.
to discontinue estrus 2 milligrams daily at 12, but you mentioned a potential bleeding if not reduced.
Yeah, so if you're on like one tab of estrase per day, you can just stop. If you're on more than one, we usually give you 3 or 4 days in between each pill that you go down. So let's say you're on 2 pills of estrase per day, God forbid, because we try to avoid that. But if you are, then you would stop one pill at 12 weeks. So you're now on 1 pill per day. And then you'd wait 3 or 4 days and then you would stop the other pill. So you just space it out by slowly, gradually going off. Progesterone in oil shots, you can just stop. And we continue our patients on the vaginal progesterone because patients from IVF do have a higher risk of preterm labor. And we don't want anybody going into preterm labor after they work that hard to get their baby. So we keep our patients on it right through till 36 weeks. And knock wood, we've had a very low rate of preterm labor. So I think it does work.
What cycle day is a FET normally performed on?
Depends on you. So if your lining's ready by day 10, 12, then by day 17, 15, 17, you'll be ready for transfer. Or 18, I guess, at the most. If your lining takes 15 days to get ready, you're not going to be ready till day 21. So there's no way to gauge that ahead of time. On average, I'd say most of our patients take about 17, 18 days all the way out to maybe 19, 20. But that's about the limit of where we're comfortable with it. Shorter than that, longer than that is probably not ideal.
Hello, Dr. V. Could you please did that. Also, I had 2 failed FETs. Third ended in a biochemical. The first positive preg test ever, but a heartbreak after. What are your thoughts on biochemical pregnancies and what causes them?
Well, the number one cause of a biochemical pregnancy would be a genetic abnormality with the embryo. So if your embryo is not euploid, meaning a normal complement of 23 paired chromosomes, your risk of miscarriage is very, very, very high. So that would be the number one reason for why it would fail. Aside from that, it could be that there's an infection, there could be an immunological problem, you can have vitamin deficiencies, you can have a problem with the structure or shape of your uterus, you can have problems with hormones, your thyroid, body mass index can be an issue. According to some people, diet can be an issue. So there's all sorts of different things. Exposure, smoking, drinking, drug use, sperm quality. It's not all about the ladies. The sperm can drive miscarriage risk as well. Guys with high DNA fragmentation have a huge increase in the risk of miscarriage. So ladies, it's not always all about you. The guys have to take half the responsibility as well, especially in those recurrent pregnancy loss cases.
Got a long one here. Ready?
Okay. Do I need to take like notes?
No.
Okay.
No numbers here.
All
We
right.
currently just finished a round of IVF and had 27 eggs with 15 of them mature.
Awesome.
We used ICSI to fertilize them and ended up with only 1 fertilized.
Whoa.
It eventually became non-viable after 2 days. There were no known sperm or egg issues going into the cycle. Above average AMH. The embryologist mentioned that my eggs had a glossy look to them after retrieval, but they had never seen that before and couldn't explain it. Have you ever heard or seen that? If so, can you suggest possible causes or next steps for what we should do before heading into our next cycle?
Oh boy. I would get a second opinion from another lab director with a huge amount of experience, like ours, for example, or anyone else, who can take a look at the sperm sample first, because fertilization failure is often a sperm issue. And so I would want to look at that and see, is the sperm okay? Is there a problem with the sperm? It might be worth seeing if they would be willing to just do like a test run for you at your clinic for very, very little to just see if some simple things would work, like ionophore oocyte activation or doing some sort of sperm selection technique, or using testicular sperm. So I'm going to be prepping a presentation for you guys soon on the benefits of using testicular sperm over ejaculated sperm in cases with fertilization failure, because it's becoming pretty clear that if you do have very poor fertilization, testicular sperm extraction is the way to solve the problem. So there are different things you can do from a sperm perspective. If they genuinely thought that the problem was the egg, that's a tough one to fix. I'd want to know lots about you. Do you smoke? Do you drink? Do you use any drugs? Did they check all of your vitamin levels? B12, iron, vitamin D. What's your thyroid like? What are your hormones like? What was your stimulation protocol like? Did they overdo it with the drugs? Would you be better trying a natural cycle IVF or a mini stim? So there's a lot that would go into that. And that's really a case where a second opinion can really make a huge amount of difference for you. And that's not to say you need to jump out of the clinic that you're with. I never necessarily push people to leave their clinic unless they're telling them to do the ERA test. But aside from that, I would definitely have a talk with someone just so you can get some valuable information for you. That's a very interesting case. I would love to take a crack at that. So if you want us to have a look, just contact info@drvictory.com and just mention in your email that I said I wanted to take a crack at this, and the girls will find a way to squeeze you in somewhere.
Please share your thoughts. The use of resveratrol for older IVF patients with diminished ovarian reserve, AMH 0.9.
So actually there was a study just out last week that looked at resveratrol for DOR patients, which showed that it was beneficial. And they think that it helps prevent something called apoptosis of the granulosa cells. So let me turn that into English for those of you that don't catch all of that. There's an egg, and then around the egg, there are all these cells that look like a puffy cloud. And those are called cumulus cells because it looks like a cumulus cloud. So the cumulus cells help provide the egg with the nutrients it needs to do its basic functions. And that's actually where all of the estrogen is coming from the granulosa cells in the cumulus. So the reality is that resveratrol stops those granulosa cells from dying. And so that could be hugely beneficial because that just means you're feeding your egg better. So there is some evidence that it works at a molecular level. We now do recommend resveratrol to all our endo and our PCO patients. After that study, we would probably start advising our DOR patients to take it as well.
Hi, Dr. Victory. Recurring fluid in lining during prep for FET. Would you recommend doing hysteroscopy? What causes fluid in lining?
We get asked this question all the time.
Yeah.
We got to do, you know what, we should do a short on that. Today?
Fluid in lining.
Today. Can you write it down or something?
Yeah.
I'm going to forget. You got to write it down.
Okay, I'll write it
Make
down.
a note.
Yeah.
So fluid in the lining. The main source is from a section scar. It's called an isthmocele. So you get this little shark fin defect in the lining of the uterus. And when that happens, it generates a lot of fluid, and that fluid can have difficulty getting out. It also is probably we call it a nidus, a focus for infection. So number one would be an isthmocele. Number two would be an infection in the lining. Number three would be that your fallopian tubes have what's called hydrosalpinx. They're swollen and filled with fluid, and the fluid is leaking into your uterus. And then number four would be your cervix is so tight, the fluid isn't getting out. So any of those are possibilities. How do you treat it? Depends on what the cause is, obviously, right? So if it's an isthmocele, you either have to burn it, resect it, or remove it. If it's an infection, you treat the infection. If it's the tubes, you got to remove the tubes. And if it's the cervix, it's easy. You just stretch it open by dilation. So that usually solves the problem. So each of these has its own little solution.
I'll be doing multiple retrieval cycles due to age and poor egg quality. I have an AFC usually of 25 to 35. Do you recommend duo stim?
Yeah. I mean, for us, we have something called triple stim, which is 3 cycles, and we reduce the price compared to, it's actually almost a third less than doing 3 cycles. So we actually have the price set so that you're basically getting the second cycle for the third cycle for free. So yeah, we definitely would encourage Duostim. Duostim is wonderful. I'm not sure I totally agree with the idea of the conventional Duostim where you do your follicular phase stim and then you immediately do a luteal phase stim because you get fewer eggs. When you split it and you do a follicular and then a luteal in a separate month, you get a lot more eggs. So we don't do a lot of back-to-back duostim. We do split duostim. And then triple stim is just choosing based on the first two which one you did better on and then doing a third one. So yeah, I would definitely recommend that. My Ember mug is taking forever to heat up.
Really,
which is quite frustrating.
It's
and I think it might be Wendy's because mine was filthy and this one's quite clean. So I don't know.
Maybe it's set to cool.
I keep hitting the button and dragging up the temperature too, and it's showing that heating, but it's slow as molasses. Anyways, onwards.
Is a 20.7 FSH good for 40 age trying to get pregnant, or does it have to be lower?
20.7 means that your ovaries have become very, very weak normally. And 20 is the cutoff for where we believe you're going into menopause. Anything over 12 for FSH is considered high. So that definitely would not be a good number. We don't really use FSH that much anymore other than to help us guide your proximity to menopause. AMH is a better predictor, although neither of them are great predictors, but AMH is a little bit more accurate. But an FSH of 20 is very high. That would usually indicate that you're very likely going to need to either try many times or consider donor egg use. So that's a long discussion you need to have with your doctor.
Dr. V, what could cause sudden above normal prolactin levels, and is this something to worry about?
Sudden above normal prolactin levels, chest trauma, breast manipulation, medications, or a tumor. Not a cancer tumor, but a benign tumor in the brain. Prolactin doesn't tend to suddenly spike. The other thing would be a thyroid problem. So you need to see an endocrinologist and figure, or a repro endo and figure out what's wrong.
Is it possible to have the set of follicles from the last cycle in the current cycle? My follicle count is each ovary is exactly the same as it was before I ovulated in my last cycle.
No. So the follicles from a previous cycle won't last until the next one, but follicles do come in waves, which is why people came up with duostim. So you may have some of those still lingering, but those would be the smaller ones, not the bigger ones. The bigger ones don't linger unless they've turned into cysts. So yeah, no, not usually. They don't hang around and wait for the next cycle.
Do you find the IUI success rate is still 20%, or do you find it's decreased for endo patients?
Oh no, it's definitely, all fertility outcomes are lower for endo patients. There's even a suggestion that miscarriage risks are higher with endo patients. I'm not convinced by that data, but it has been suggested, and there are studies saying, look, the miscarriage rates are higher. As of 2 days ago, I think, there was a research article and study that demonstrated that there is a relatively strong association, not hugely strong, between a bacteria called Fusobacterium in the uterus and the presence of endometriosis. So 63% of patients with endo had Fusobacterium in their uterus compared to something like 13% or 12% or something who didn't. So big difference. And so that data is supportive of the idea that there may be an infection leading to endometriosis. And because we know that infections in the uterus increase the chances of miscarriage, there may be a connection between the two. Again, not 100% proven yet, but an interesting area of inquiry. And so now they're actually saying, should we be treating endo patients with antibiotics, which is fascinating. And apparently there's a trial underway.
Could you go over HRT one day on the show?
HRT FET or just the risks and benefits of HRT? See what they say. Yeah. When they answer, let me know. Because I love HRT because I actually, so years ago at the American Society of Reproductive Medicine meeting, I won this really coveted prize called the General Program Prize. So I got awarded the highest prize for the whole entire conference for using the Women's Health Initiative data to show that women that took the birth control pill actually had lower risks of cancer or heart disease, all sorts of different outcomes. The Women's Health Initiative went ballistic. I had to fly to Washington, D.C., defend my paper, and they already had prepared a letter for me to sign saying that what I had done was in error, which I, of course, never signed. And so we never agreed to signing that because everything we had done was correct. And even the American Society of Reproductive Medicine said, yeah, like this is fine. And they didn't take away the award or anything. So I love hormone replacement therapy. More than happy to talk about that if you want to know about that. So not everything we do is infertility. Some of it is hormone related. I'm impressed that your phone has stayed on that angle the whole time.
It's a good slope.
That's impressive, yeah.
It's a good slope. Can I ask a question about PCOS?
Sure.
I've been seeing a lot of videos about
Carnitine
and berberine as supplements to help treat the symptoms of PCOS.
Yeah.
Is there any truth to this? And is it something you would recommend?
Yeah, so in a video we have from years ago, which we should probably bring back because it was a good video, but we need to do it again. We reviewed the natural supplements that work for PCOS. So if you look at that video, berberine, I believe, was in there. It's definitely in there for endo. So there is data that shows that it's helpful. I'm not familiar with the L-carnitine PCOS data, but I can tell you that we use NAC, NAC, has proven benefits. Inositol, definitely proven benefits. Resveratrol, proven benefits. Coenzyme Q10, proven benefits. And now we use ALA as well, which also has proven benefits. So all of these have some studies that support their use. None of them, be really cautious with this data. None of them show that you have a higher chance of live birth. But do they help control symptoms, increase ovulation, that kind of thing? Yeah, they do. Can they improve your insulin sensitivity? Yes, they can. So it's definitely worth looking at. The human body is a pretty amazing thing. I had a chat with a patient today who was understandably upset because her family doctor had told her to not see a naturopath. We actually have naturopaths at each of our sites. We work hand in hand with them. Your body is not entirely dependent on some scientists figuring out a chemical in a lab that helps cure this, that, or the other thing. Nature is full of stuff that helps us, right? I mean, penicillin comes from nature. So there are lots of natural things you can do with diet, with yoga, with meditation that improve your health and have actual physiological changes. Acupuncture, traditional Chinese medicine. Lots of these things have proof for their benefit. So don't disregard or discard all of that out of hand because we live in a society where you have a symptom and somebody pops a pill for you. Don't get hung up on that. It's not all about that. Especially with fertility care, it has to be holistic. It has to be. That's how you get the super success rates. If you're just seeing someone that's pounding you with hormones, you're getting mediocre care, in my opinion.
Is IUI or IVF more effective on a woman in her 40s? And are there any success rates on IUI on an age group in their 40s?
Yeah, so if there's no question that IVF is always more successful than IUI. So you're always going to get a better chance with IVF. In your 40s, if you look at the European guidelines, they suggest one attempt at IUI over the age of 39 and then go straight into IVF. If you look at a Chinese study that we reviewed probably a year and a half, 2 years ago on the show, which is, I think it's How Many is Too Many is the title of the video on our YouTube channel, then you'll see that over the age of 38, the maximum number of IUI you want to do is 3. And that total gave you a 19% pregnancy rate. Above that, it was 0. You weren't going to get a success after 3 tries. So we don't do it more than 3 times in that age group. So those are the numbers you're looking at. IVF is completely different, right? If your ovaries are strong, you have a very good chance with IVF. If your ovaries are weak, you don't have a good chance with IVF, but you have an even worse chance with IUI. So it all depends on the strength of your ovaries, the quality of the sperm, all of the other things we always talk about, BMI, health habits, eating habits. All of these things are important.
Can adenomyosis cause implantation failure or early miscarriage?
Yes, to both, definitely. Adenomyosis can definitely cause failure, and it can likely cause miscarriage as well. There's all sorts of molecular level studies showing disruptions in the endometrium for adenomyosis, and I actually just reviewed an article to be published for the journal where the authors had actually examined the relationship between adenomyosis and implantation and whether it increases risks in pregnancy. And there are other, without getting into any of the specifics of that article, because I can't, there are previous articles which show that it does have an impact.
Is anything safe to take for a sore throat or cold while breastfeeding? Dayquil and Halls seem to have ingredients that harm supply.
So Halls is fine. It won't harm your supply. So if you need a Halls, take it. I don't think they make chloroseptic anymore, but that would be fine too. That stuff you spray, which numbs you. You should get checked to make sure it's viral versus bacterial, because you may need antibiotics. But yeah, anything over the counter is probably going to be safe and shouldn't harm you in breastfeeding. If you're looking at decongestants, you could dry up a little bit of your milk supply, but only if you're on it for a long time.
Dr. V and Tenacious T.
Tenacious T.
If lining is fine for FET,
Yeah.
do you have an opinion around estrogen levels day of, before an FET, and post FET, especially for endo post-lap patients avoiding estrogen? Thank you.
Yeah, so there is a study we reviewed ages ago which showed that you wanted at least a level of 100 picomoles, but we don't bother paying attention to the level of estrogen. So I don't find that makes any difference. Unless it's woefully low, then I'll give people a little bit of estrogen. But estrogen levels, I don't think make any difference. If your lining is fine, your lining is fine. You're physiologically getting enough estrogen. And don't forget, there's a huge difference in what's in your bloodstream and what's acting inside your uterus. So we can't measure that properly ever with any hormones.
Hi, Dr. Vinti. Would transferring a lower quality embryo with a better quality embryo hinder the better quality embryo implantation and development?
No, that's been studied before and it doesn't do anything. There's this guy by the name of Macklin who has this incredibly cool video under electron micrograph of dropping an embryo into a dish and then putting endometrial cells around the embryo. So, and obviously it's under fluid, right? Because the embryo has to survive. So in the genetically normal embryo, the cells from the endometrium actually migrate towards the embryo. So it's obviously sending out some kind of signal which says, hey, I'm here, come attach to me and support me. And the abnormal, the genetically abnormal embryo, the cells don't move. And it's the coolest thing I've seen really in my career. So that's a fascinating video. But the important part about that is the good one won't interfere with the bad one. It's because the bad one won't interfere with the good one because the good one is actually telling the cells to come to it.
Right after a chemical pregnancy, are you more fertile to do a frozen transfer right away or
No.
ever the extra? Or even the next or even the next that's it.
Yeah, no, you're not more fertile. Not at all.
Hello to both.
Hello to both. No answer back on HRT?
Let's see.
Before
You have multiple levels of comments, so I take turns here.
All right.
HRT, no follow-up to the HRT.
No follow-up on the HRT question. Interesting.
HRT got shy.
Okay. Follow.
Back to where I was.
Yeah. Hello to both.
Hello to both.
Okay.
That's nice. How many milligrams of fish oil and CoQ10 do you recommend? Thanks for all you do. Big hug to both.
Aw. So fish oil depends on the formulation and whether you're 369 or 3 or whatever the formulation is. So can't really answer that one. Coenzyme Q10 depends also on the formulation. Normally, with the majority of products out there, it's 600 milligrams that's recommended. With Neo Q10 from Theralogics, it's 125 because there's incredibly quickly absorbs into your system.
In the Receptiva DX.
Oh God.
Yeah. Yeah.
Yeah.
I don't even know if I should continue the question or just stop here and have you get, you know.
Well, you love teasing me with the arrow ones.
I get really excited when I see these.
No.
These comments automatically create a grin. Is the Receptiva DX and CD138 test accurate in diagnosing endometriosis?
No.
Do you recommend it?
No.
Do you recommend it?
No. No. Receptiva DX has been proven to be useless. It will not alter your cycle management, so don't bother.
It's just so great. I'm 17 weeks. I'm 17 weeks.
Congrats.
I'm 17 weeks pregnant with persistent vomiting. I have
Oh.
tried Declectin, Gravel, Zofran, and Maxran. The vomiting didn't stop 100%. Besides that, I didn't gain and weight. Any advice?
You need to go see your doctor and figure out what's wrong. That's not one I can advise on the show, but you definitely need to see someone if you're not able to gain any weight in your 17 weeks. So I would strongly advise that you see your physician or the obstetrical triage unit near you and get appropriate care. In general, if you look at people that have, non-stop vomiting and they can't hold anything down, we'll get gastroenterology involved so that sometimes they have to scope patients to figure out what's wrong. One thing I frequently recommend to patients is to get additional testing done. So whether it's a scope or H. pylori testing or whatever the case is, there are extra tests that can be done to see if it's something more than just the pregnancy itself.
Do you think adding an antihistamine protocol, example Benadryl, Quercetin, Zyprexa, a week before FET can help improve implantation chances?
So I've looked it up, and there's no evidence to support using antihistamines at all. In fact, I'll do it again today.
What would be the logic to it?
Reduce allergic immune
response.
reactivity.
Oh, I see.
Yeah. Let's go to.
Because when I take my allergy pills,
Yeah.
my eyes itch less.
Thanks for that.
Yeah, I thought that was important for people to know. You know, the non-related comment.
That one.
There's a time for that.
That was genius.
Yeah.
That one, I'm taking that one to the
I
bank.
felt people need to know that.
Do you actually get allergies?
This year, it just started. Somehow
Seriously?
my eyes get suddenly itchy, and I don't know what it is. And I'm going nuts.
Dude, you're failing us as Middle Easterners. We don't get allergies.
There
There are no Middle Easterners that get allergies.
My wife is actually challenging my manhood
Just-
with this moment. She said, "What kind of man gets allergies?" I'm like, "I don't know." So I stopped taking any medication. I just go around my house wiping my eyeballs all day because I refuse to take any medication.
Because you won't take the meds?
Yeah.
Yeah, well, I feel for you. But yeah, I don't know. Although Windsor is like supposedly the worst city in Canada for allergies.
I'm sure there's something in the air here.
Probably.
Yeah, I'm sure.
Yeah.
I'm being set up. I feel quite manly 99% of the time, so not sure what this is.
Go ahead.
Okay, while you do that,
Yeah.
Ari doesn't believe my results from Fertility. This is the best question ever.
Oh, jeez.
Hold on, let me start this again. I need to give it the right accent.
This is getting specific. I like Ari. He's a friend of mine. I don't want to get in any trouble. Yeah.
RE doesn't believe my results.
Oh, R-E, not Ari.
Yeah.
A-R-I.
Reproductive endocrinology. Yeah,
Okay.
endocrinologist. One of your colleagues.
Okay,
Parentheses.
got it. Yeah. Okay.
Doesn't believe my results from Fertility and won't prescribe
Oh.
antibiotics.
Okay.
None. Any tips on how to bring it up again? My results showed uroplasma and staphylococcus.
Any advice on how to bring it up again? Explain the test and say that this is a test that looks for the DNA of bacteria in the sample, and therefore it's impossible that it's not there. It's not like a false positive. And they even compare it to the vaginal, so you know whether it was contamination or not. And so ask them how they can say it's not there. More importantly, I guess I would say ask them to provide proof that endometritis is not important, because there is none that shows that it is not important. So I think they'd have a hard time justifying that. I will say, if you are with someone who is refusing to accept the results of a test that clearly is valid, at least as a test, you could argue whether or not the results need to be treated. That's a different argument. But at least as a test, if someone's questioning that test, then I guess I would say you're wasting your time. You should be going to a different clinic. Like, we get
I can
weird.
write them a script if they need.
You could write them a script, yeah.
I feel confident.
We get all sorts of requests from patients all the time, and I go and I look. Like, I research all the stuff you guys ask about, like antihistamine protocol. I'm looking it up right now during the show to see if there's something new. So, you got to work with people that actually will find stuff. Okay, so I'm looking, by the way, for antihistamine. No randomized controlled trials, 0. I typed in antihistamine and FET. Clinical trial, none. There's nothing. There's literally nothing on antihistamines. There's 5 studies. And I spelled it correctly and everything. So maybe I'll try frozen embryo transfer. Go ahead. I'll take the next question.
It's a tricky word to spell, so you wouldn't be.
Oh, look at that. There's nothing. There's not I wish I could show you the TV screen, but there is not a single study examining antihistamines and FET. So does it work? No clue. There's still no studies.
Helps with itchy eyes. Helps with itchy eyes.
But it's helping Tarek's itchy eyes. Yeah. So I guess that's something. That's something.
Serious question.
Okay, serious question. My tea finally warmed up.
Well, there you go. Is there a BMI restriction at your clinic? If so, what is it and why? Thanks.
Oh boy. Okay, so yes, no, and maybe. So we cannot force anybody to do anything. We only have recommendations. We do try very hard to keep the BMI under 40 because pregnancy is very significantly more complicated once your BMI is over 40. It's actually more complicated anytime you're over 26, but over 30, it's a little more complicated, tolerable. Over 35, it's way more complicated. Over 40, it's dangerous. It's actually dangerous. You have a risk of wound complications, cesarean section complications, death, blood clots, severe hypertension, preeclampsia, stroke, all sorts of different things, preterm labor, stillbirth, miscarriage. All of these risks in pregnancy are much, much higher when your body mass index is higher. The problem we run into is what I call the inflection point between where your weight or body mass index and your success rate kind of go on the teeter-totter. And that inflection point is 38. So when you are less than 38, and there are 2 studies, we actually reviewed one on the show a couple of weeks ago. So when you are 38 and younger, it is better to lose the weight because your chances are going to stay reasonably strong. And as long as you lose a substantial amount of weight, we're not talking about 5 pounds here. As long as you lose a substantial amount of weight, your success rate is higher with the weight loss, despite the delay in order to achieve the weight loss, than it would be if you went ahead and did fertility treatment while you're struggling with your body mass index. Over 38, it's the opposite. Your ovarian reserve is getting progressively more compromised, and so it's actually safer to go ahead and make embryos than it is to delay. Having said that, there is an upper limit to what's safe for us in terms of providing you with anesthesia, so that becomes a problem. So if your body mass index is over 40, we sometimes need to have other individual there, like an anesthesiologist, just to protect your airway and things like that in case there is a problem. But as a general rule, we don't do IVF on people over 40, and we try to discourage younger people from trying to get pregnant when their body mass index is over 40, because your risks are very substantial.
Seems quick. That's the time. You have like a million billion questions.
Oh, really? Another big show?
Yeah.
10 minutes?
Sure.
Okay.
I did that. Going back to the lining fluid,
Okay.
if you recall.
Yeah.
Is the isthmus detected during a hysteroscopy?
Yeah.
And can it be removed during that procedure?
Removed? No. Resected? Yes. Burned? Yes. Detected? If they're looking for it and they know what to look for, yes. We normally just do a saline infusion sonohystogram. You can see it clear as day. You don't need surgery to see it.
Can endo be diagnosed during a C-section?
Yeah, sure. But it's difficult because the uterus is really big and we don't go behind the uterus to look unless you're one of those people where the doctor has pulled the uterus out of the abdomen in order to close it. I don't do that because the studies show that it increases fever and pain. But some people do. So for those that do, they could look behind the uterus and see if there's endo.
I fast forwarded the comments a little bit, but I'll read it for you because it seems to be funny. Hey T and Dr. V, I enjoyed last week's video when you guys cracked up at T. You guys are the best.
That was so funny.
Yeah. Hey T and Dr. V, starting stims this cycle, I decided to do Frozen. Hope I'm... I don't know, that's it. I don't know. That's all it says. Hope I'm...
I hope you're successful.
Yeah, there you go.
There you go.
How long can an embryo be frozen for?
The belief is it's probably good with the new technology, which is vitrification, for about 300 years, but obviously we don't know that. So a very long time is the suspected answer.
Hi.
Hi.
I'm 42.
Okay.
And my doc decided to freeze my 3-day embryos.
My 6 3-day embryos. Okay.
Can we unfreeze and test? Or what do you think is best? Just implant the untested embryos and hope for the best. And should we use embryo glue, and can or should we do hatching?
Okay, so yes, you can thaw and grow out your embryos till day 5 and then get them PGT tested, but then you will have to refreeze and then rethaw, which I personally discourage it as a general rule. So I would not necessarily recommend that. Depends on how many cycles of IVF you've done, how many you can afford. There's some different variables that go into it, but it is possible to answer your question. The second part of your question is, would I do that? Probably not. And then, can you biopsy them on day 3? Not on day 3. You can't hatch them on day 3. We normally hatch on day 4 or day 5. So that's when the hatching should be done. And there's actually a recent study that says that day 5 actually may be best. So I think that was all the answers.
And embryo glue.
Oh, embryo glue. Yeah, we use embryo glue. So yeah, there's no question. Embryo glue is beneficial. There's lots of information on it and a meta-analysis. Everybody should be getting embryo glue.
And she continued the question, do you stop clients with DHEA when about to transfer if previously on it before retrievals?
I stop my clients from being on DHEA once I'm done the retrieval.
If previously on it
They
before
shouldn't.
retrievals.
Yeah, we don't keep you on it through your embryo transfer usually. There might be some people that could benefit from it, but generally speaking, no.
Hello to the best team.
That's worth a high
You,
five.
me.
That's you, me. Yeah.
Yeah. What milligram do you recommend taking of fish oil and
Oh, they asked that.
curcuma?
Curcumin 60 milligrams from Theracumin. That's the one we use. And fish oils, it depends on the formulation. Usually it's like 3 milligrams, but it depends on which formulation.
Does it make sense to do unmedicated IUI? I had all my tests normal and my husband's semen analysis was not great, but normal.
It depends on your clinic's success rate. Some clinics have a good success rate with natural, and so you could try natural. Some clinics, and I would probably say most, have a higher success rate with pills, like Clomid, for example, and then an even higher success rate with shots. So if you look at the research, the hierarchy is natural, pills, shots. So we generally use pills at least, and sometimes shots, but we do some natural. It's up to you. You got to talk to your clinic though and see what their success rates are. Natural with IUI average probably 7 or 8% success rate. Pills and IUI 10 to 15%. Shots and IUI 20-25%. So depends on what you're looking for out of it, because there are risks and benefits. One or two more.
Up to you, whatever you want. You make the call. I'll give you one.
I'm on call tomorrow night.
Yeah,
so I need to sleep tonight.
Last question.
Last question.
Not related to fertility.
Oh, cool. All right.
Okay.
All right.
Would you ever go on a submarine to see the Titanic?
Oh, I shouldn't laugh. That's terrible. Oh my God, those poor people. That must have been terrifying for them. God rest their souls. No, because I watched the Meg and I don't want to be.
Oh, you think the Meg's down there?
Yeah. I scuba dive. I've gone down in Hawaii when there was whale mating season. You can hear the whales under the water. It's very freaky. Would I go down in a submarine to see the Titanic? No, I wouldn't. And those, did you hear what they paid for that?
I heard.
It's $250,000 to go down there.
Good.
And the company was already sued by one of their employees for safety violations.
Really?
Yeah, I don't think you're coming back from that. So, no, I would not go down to see the Titanic. I loved watching the movie, and that was wonderful. But that's as close as I'm ever going to get to the Titanic. Yeah, maybe flying over it. That would be the only other thing. We're done? Okay. Have a great night, guys. If your questions didn't get answered, we will endeavor to get to them. I have a list from last week, which I will try and do on call tomorrow night. And thank you for watching. Make sure you tell all your friends. Thank you for watching our TikTok. Don't forget to leave comments. And we have more exciting videos coming for you soon. Take care and have a good night.